I'm gonna bribe y'all. Who wants candy? What's the information? Anybody got an idea? Huh?
Can I answer?
Yes, you can. Come on. Yes, you in the red.
It's your fault biting off an infection or
I like that answer. Okay? I like that answer. I got somebody to pass out some candy for me, Miss Ebert. You come out or Colleen?
Let's both do it.
Let's do it. Okay. So, it's my new clicker.
It's not working?
No, my clicker ain't working.
I'll put it in there. I might have to do it quicker.
Okay.
Where did you plug it in at? Down in the tower.
Okay. So according to y'all's textbook, definition of inflammation is adaptive response to injury or illness that brings fluid, dissolved substances, and blood cells into the institutional tissues where the invasion or damage has occurred. Okay, next slide. So as you see, I love our nice little picture here. Tells you how your body's going to react to all this stuff when something injures your body. It's giving you a warning that, hey, I don't like this, y'all need to fix it, okay? So we're going to do a little quiz here. So what I did was I used some of my own resources and stuff. And we're going to talk about appendicitis first. The question is, a healthcare provider writes the following admission orders for a client with possible appendicitis. Which order should the nurse question? Yes. A. Why do you say A? All right, I like her answer. That's correct. Applying heat to the abdomen because it increases the circulation, okay? Analgesics are held until a definitive diagnosis is confirmed for appendicitis. NPO in case surgery is needed. And IV fluids to replace lost body fluid and keeps the patient hydrated. Question 2. In preparing the client for surgery, the nurse should anticipate which of the following interventions. Select all that apply. We got administer an enema. We got maintain NPO status. We have administer IV fluids. And we're going to apply heat to the abdomen. And ensure the client signs a surgical consent form.
Somebody other than Dan. B, C, and E. Maybe not C, but E and B.
And remember, this is select all that apply.
Say it loud and proud, baby. B, C, and E. B.
Sounds good to me. And you are correct. Applying the heat and producing an enema increases the risk of perforation. Which position is best for a patient with suspected appendicitis to be placed in? You got semi-Fowler's, supine, prone, and lateral recumbent. And the lady in the red? Anybody else got another choice? A. Semi-Fowler's. Good answer. Semi-Fowler's, if there's any drainage from that appendix, it's all contained in one area. Okay?
I am bad. I am so sorry, Crystal.
Okay, we got a teacher knocking people out. Okay. What are the signs and symptoms of appendicitis? Select all that apply. All of them. I like your answer. It is all of them. Okay? She's kidding. All the signs or symptoms of appendicitis.
Can you go back?
Uh-huh.
Thank you. No. Okay.
All of them. You good? Okay, all of them are. Last question. Blank is inflammation and bacterial infection of the entire abdominal area. Peritonitis, correct answer. What's cellulitis? Skin tissue, okay? What's endocarditis? Around the heart, okay? And gingivitis. I'm getting them all in there. I'm getting all those itises in there, okay? Food grade is peritonitis, that is the correct answer. This one is severe, this can lead to death. So it's very important, if you get an appendicitis patient, you go ahead and get them treated properly, okay? So what is appendicitis? Basically, it's inflammation of the variform appendix, the common cause of abdominal pain, emergency surgery in many cases, and occur at any age, but mostly adolescents and young adults. So you'll mostly see this in younger children. And as you see, we got our little guy here with appendicitis. It's rare in children under the age of 2, and how it starts is a dull, steady pain around your belly button, and it rotates to the right lower quadrant over 4 to 6 hours. You have a low-grade fever. Once this pain hits, you start getting nauseated and everything. Don't want to eat. So you don't want anybody touching it. You're guarding it. Your white blood count is elevated, and the diagnosis test is an ultrasound. To fix this, it's an exploratory lab. Okay, why we have this infection? The obstruction of the appendix lumen is usually caused by a hard mass of feces. You gotta think about where your appendix is. It's on the bottom of your colon there. Other obstructive causes are calculus, stones, parasites, edema of lymphoid tissue, tumor, or a foreign body. Risk factors, it mostly affects males. Having a low fiber diet, GI infections. It cannot be prevented, but diet high in fiber can decrease your incidence. Diagnostic tests, we talked about the ultrasounds. There's some other tests they can do. Elevated white blood cells with increased immature white blood cells is another indication of it. Surgery. Things for surgery you need to know is you're going to do some IV fluids and you're going to do some antibiotics. They're going to do your 3rd-degree antibiotics, cephalosporins first. They're broad spectrum and they're good at fighting this type of infection. So our first video. Escape, okay. And then the mouse, okay. First one?
No, I just usually use this.
Okay. Okay. So, appendicitis requires surgery in most cases. This right here is a short little video of what a laparoscopic appendectomy looks like. Because if you work on a surgical floor, your patients will ask you why they have all these small incisions in them, okay? And what to expect. We have to get this video.
Removal of the appendix, called appendectomy, is performed when appendicitis is suspected. Right lower abdominal pain, fever, and elevated white blood cell count are common symptoms and signs of appendicitis, which usually occurs when a blockage develops between the appendix and the intestine. This leads to infection, swelling, and distension. If the appendix is not removed, it can lead to a life-threatening perforation or rupture. The only treatment for appendicitis is appendectomy, which is almost always performed on an emergency basis. Newer laparoscopic techniques require only tiny keyhole incisions or puncture wounds, which generally result in a shorter recovery period. Before your surgery, an intravenous line will be started. Appendectomies are done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be temporarily inserted through your mouth and into your throat to help you breathe during the operation. A catheter may also be placed in your bladder to drain your urine. An uncomplicated laparoscopic appendectomy usually takes between 20 and 30 minutes. To gain access to your appendix, your surgeon will use sharp instruments called trocars to create 3 small holes or ports through your abdominal wall. These ports are usually located at your navel or umbilicus and in the upper right and lower left quadrants of your abdomen. Carbon dioxide gas will then be pumped through the umbilical port to puff up your abdomen so its contents can be viewed more easily. Next, your surgeon will insert the laparoscope through the umbilical port. Images from its camera are projected onto a video monitor in the operating room. Your surgeon will carefully examine the inside of your abdomen, confirming that your appendix is red, swollen, and needs removal. At this point, your surgeon will pass surgical instruments through the other two ports, grasp the appendix, separate it from the intestine, drop it into a specimen bag, and remove the specimen bag through one of the ports. After your appendix has been safely removed, your surgeon will instill warm, sterile salt water through one of the ports into the abdomen to cleanse the abdominal cavity and remove any traces of infection. The salt water is then suctioned out. Before removing the laparoscope, your surgeon will take one final look around for areas of bleeding or other damage. When the laparoscope is removed, a port valve is left in place briefly to allow all the carbon dioxide to escape from the abdomen. Finally, the keyhole incisions are closed with sutures or staples and covered with bandages. At the conclusion of the surgery, your breathing tube and catheter will be removed, and you will be taken to the recovery area for monitoring, where you will be given pain medication as needed. When you are able to drink liquids, your intravenous line will be removed. Most patients can leave the hospital within 24 hours.
Okay. Okay, so your patient comes in with appendicitis, severe abdominal pain. If all of a sudden their pain stops, that's a good sign that their appendix has ruptured, and now we're talking about peritonitis. That is, like I said, it's a life-threatening illness. It needs to be taken care of ASAP. As in the video said, if it's a good, clean appendicitis, 24 hours in the hospital with some antibiotics. Peritonitis kicks in, we're talking 2 to 3 days of IV antibiotics before you even think about discharging you from the hospital. So it's very important that you need to monitor your patient, check for how their pain level is, okay? Nursing process. So a patient that goes in and has surgery, some of the things that you need to look at. You need to promote their effective respiratory gas exchange. Like you said, they had gas pumped into their gut to lift up their organs so they can get to see what they need to see. They need to get that gas out. They need to be able to breathe. Get them up, ambulate them, have them split that incision to get up and move, because these people are not going to want to move because they've had surgery. It's still a painful surgery. Use that incentive spirometer. We don't want pneumonia and all that sitting in. You need to promote IV fluids. Like I said, they're going to still have some IV fluids for a little bit, and then they're going to gradually start off with clears to get to a regular diet before they go home. And you're going to monitor their intake and their output. So, another thing is you need to prevent infection. Like I said, if they've got 3 surgical sites, you need to look at all of those sites, make sure there's no signs of infection. What are some of the signs of infection?
Redness, warmth,
Tenderness, warmth. Okay. Pain management. They're going to be probably on some IV pain management when they first get out of surgery, and then they're going to initially switch them over to oral pain management. We need to monitor that too. And patient education. When this patient is discharged, you need to educate them what they need to look for. If their pain's not getting any better, look for signs and symptoms of infection. That's another thing. Okay, this is an old little picture here. Pretty much pre-op checklist day of surgery. This is what's going to happen, okay? You're going to do some education with that patient, what the surgery's going to be like, what to expect. You need to have the informed consent. This person has to be alert and oriented, and of age. Going to be NPO. Now, with appendicitis, they don't do a bowel prep, so we won't be doing that. We're going to do a skin prep, make sure that surgical site is clear. We're going to do a chlorhexidine bath, prevent bacteria. They have any valuables, all that's going to be done. They want them to void before they get transferred to the OR. Any pre-op meds are given and charted. So So like I said, remember your national patient safety goals. We talked about no surgical infections. That's why they have that cephalosporin on board before they do that first incision. It's to prevent infections, because we don't want to get dinged for that by JPO. Side rails are up. Hospital gown. Allergy ban, very important. Need to know about that. Of course, their ID. If they have any type of medical equipment, dentures, hearing aids that needs to be moved. Vital signs. Pre-lab labs need to be done. Any abnormal labs that doctor needs to know. And then their medications, what kind of meds they take at home. Make sure we don't have any interactions with other meds that we need to give them. That's one thing we need to do. Okay? So we're going to talk about this for a minute. You are working in the ED one day, and you see a couple come in with a 10-year-old child having severe abdominal pain. It looks like appendicitis and all this, thing like that. And doctor does his assessment in them, calls in. It is appendicitis. After they did the ultrasound, they see that. General surgeon is going to be called. We talked about what goes on. Who's going to sign that consent? Is that little 2-year-old boy going to sign that consent? Okay, it's going to be his parents, okay? What other things are you going to need to start in that ED before this boy goes to surgery? You're going to do some education, okay? How about medications? IVs and all this stuff. There's some other orders you're going to look at, okay? Anything else y'all want to know about his eyes? No. Huh? You're going to know that. You're going to do the patient history. That's right. You're going to get all that stuff done. So, that's it all I got on appendicitis. Y'all ready for the next one? I'm going to do the short and sweet today, okay? GERD. Gastroesophageal reflux disease. What happens, your gastric contents are flowing backward into your esophagus, causing you to experience heartburn. Rick, I think something's wrong with the septic system. The toilet is flushing kind of slowly. How many of y'all in here have little ones, like 2 or 3 year olds? Y'all are in the process of potty training. Okay. I'm on my 4th one right now. It's my granddaughter. And if you ever potty train a child, everything they get their hands on, they baptize in the toilet. Heads up, okay? Seriously, this is my 4th one. Both my kids did that. My first grandchild, now my 2nd grandchild. Everything goes to the toilet. So of course, things are going to get backed up, and it's going to cause a little problem here. So what it is basically GERD is pressure differences between your stomach and lower esophagus, and it's preventing backflow of your gastric content. This may result from a transient relaxation of the lower esophageal sphincter, or incompetent lower esophageal sphincter, or increased pressure in or within the stomach. Contributing factors: increased gastric volume, positioning that allows gastric content to remain close to the gastroesophageal junction, like laying down. That's what they tell you after you eat, don't lay down. Increased gastric pressure. If we are overweight, wearing real tight clothing, that can increase the pressure. Other risk factors: obesity, I'm one of them. Excessive alcohol consumption for people that smoke, any history of hiatal hernia, and pregnancy. Why do you think GERD affects pregnant women? It's pushing everything up. Very good. Yes, that's very common in pregnancy. How can we prevent this? Doing the behavioral and routine changes in our lifestyle. Eating smaller meals, and more frequent smaller meals, okay? Don't treat every meal like it's Thanksgiving. Avoid or minimize foods that stimulate acid production. Orange juice, tomatoes, coffee, wine, chocolate, for me, it's sweet tea. If I drink too much of that, that irritates mine. Avoid eating close to bedtime or nap time. And if you do, elevate your head to the bed to prevent stomach from pressing on the lower esophageal sphincter, and avoid wearing tight clothing. Let's see. Pharmacology. y'all need to pay attention to this. I know we're far from taking this class here now. You need to know this. You will see this, what's it, next semester?
Yes, ma'am, next semester.
Y'all need to know this. There is a lovely chart in your textbook about all these medications and what you need to monitor on them, okay? And acids, as you see. I carry this with me at all times, okay? Tums. Your proton pump inhibitors, omeprazole, Prevacid. Y'all just did y'all's medication pass, y'all passed out medications. So this week, when y'all come up to do clinicals, you're gonna see omeprazole on just about everybody's mark. You need to know what it is, okay? That's the most common drug they pass out. It's given like an hour before they eat, and it helps, decrease the fluid, the gastric flow. H2 receptors, Tagamet, Zantac, and Pepsid are examples. And promotility agent, Reglan. You'll see that too. A lot of patients that have nausea or vomiting, go give them some Reglan. So look at that chart in your textbook on these medications. I would know that if I was y'all. Okay, this is my last little video. Escape. So there is a surgery for chronic GERD, and this is it right here.
Gastroesophageal reflux disease, also known as GERD or acid reflux, is an illness where stomach acid refluxes or flows out of the stomach and up into the esophagus. This is usually caused by a weak lower esophageal sphincter, LES, a muscle that acts like a barrier between your stomach and esophagus. It may also be caused by factors that affect stomach or esophagus function, such as an abnormal bulging of the stomach through the diaphragm called a hiatal hernia. When exposed to stomach acid, your esophagus, lungs, and vocal cords become irritated. This can cause symptoms such as heartburn, difficulty swallowing, chest pain, sore throat, coughing, hoarseness, or breathing problems. Common treatments for these symptoms include changing your diet to avoid foods that weaken the LES, or taking medications such as proton pump inhibitors, PPIs, or H2 blockers that lower stomach acid production. These treatments may help you feel better, but they do not treat the reflux that can still cause damage or symptoms. If left untreated, reflux will continue and may cause additional health problems, such as Barrett's esophagus, or even esophageal cancer. If your symptoms cannot be controlled by diet or medications, and you have severe acid reflux, surgical treatments are available to fix the cause of the disease. A common surgical treatment for acid reflux is fundoplication surgery. In this procedure, the top of the stomach, or fundus, is wrapped around the base of the esophagus and sewn into place to support the LES. During meals, the stomach will then stretch, causing the fundus to tighten around the LES and prevent reflux. If you do not have a hiatal hernia, an endoscopic version of this surgery, called incisionless fundoplication, is available. In this version, doctors fold the fundus inside the stomach and tack it into place below the LES to create a natural barrier against reflux. Other minimally invasive reflux treatments include stratotherapy and LINX surgery. In stratotherapy, doctors use an endoscope to tighten the LES with radiofrequency, RF, energy. The RF energy helps strengthen the LES and can reduce the frequency of acid reflux. In LINX surgery, a small ring of magnets is placed around the weakened LES. The magnets stretch to allow food and liquid through when you eat, but help keep the LES closed to prevent reflux at all other times.
some of the things as a nurse you're gonna do to take care of your patient?
Pain management,
Pain management,
education,
education,
comfort.
okay,
Imagine this.
that's
You've
it.
just made yourself a delicious